right. Welcome everybody to MUHC Medical Grand Rounds. Thanks for joining us today. Before introducing Dr. Bernatsky, who will introduce our speaker, I'd like to acknowledge that McGill University is situated on the unceded territory of the Kanien'kehá:ka and is located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. Important to make sure that your microphones are on mute. Please enter your questions in the chat for the question and answer period. Without further ado, I'll ask Dr. Bernatsky, one of our star clinician scientists in the Division of Rheumatology, to present our session.
Thank you. Dr. Harvey is a great speaker. I know you're going to really enjoy this presentation. She is a cardiologist and researcher, originally from Australia. She came to Toronto for her postdoc and stayed on to eventually become physician-in-chief of the Department of Medicine at the Women's College Hospital in Toronto. She's also co-director of the Cardio-Rheumatology Network within the University of Toronto, where she has a special interest in autoimmune and inflammatory rheumatic diseases. Dr. Harvey recently co-authored guidelines of the American College of Cardiology regarding monitoring for hydroxychloroquine cardiac toxicity, which, as we will see, is an increasingly important entity. Thank you so much, Dr. Harvey.
Thanks very much. It's a pleasure to be here today. This is a topic that's very close to my heart. Anyone that's heard me talk about this before. So I'm really pleased to be able to get some information out there to rheumatology today. So, computer is frozen. Here we go. I always give my disclosures, very little to disclose, just some CIHR and Heart Stroke Foundation grants, a few honoraria for CME, and I am the co-founding director of the University of Toronto Cardio-Rheumatology Network. So just for those of you who are not aware of this network, this is something that I've set up with my colleague, Dr. Lee Ida, who's a rheumatologist and a scientist, also interested in cardio-rheumatology. So we've set this up. It's based at Women's College Hospital, but we collaborate with our colleagues across the University of Toronto, and we really have the aim of trying to improve diseases in patients with inflammatory rheumatic disorders. And at Mission, we clinical research primary prevention clinic. We also are a referral centre for complex patients, and that's how I come to be doing this work in antimalarial cardiotoxicity. We do a lot of different research in our patients, and we're also interested in knowledge translation to clinicians, researchers into patients. So that's the Cardio-Rheum network. All right. So I was just saying that we manage patients with a myriad of complications from autoimmune and inflammatory rheumatic disorders. And this is actually taken from a publication that I did with my colleague, Dr. Attari, where we looked at all of the different complications from patients that we do see in patients with inflammatory rheumatic disorders. And today I'm looking at, obviously, antimalarial-induced cardiomyopathy, which is a complication of related to the use of medication in this patient cohort. So the objectives at the end of this presentation are as follows. I'd like you to be able to explain the pathophysiology of antimalarial-induced cardiomyopathy. And I'm going to use the acronym AMIC because it's nice and concise. Hopefully you'll be able to recognise some of the clinical features suggestive of AMIC and have some idea how to recommend a risk-based approach to screen and monitor for the development of AMIC in patients treated with long-term antimalarial therapy. So I don't need to tell everybody here at this meeting that antimalarials, and this is both hydroxychloroquine and chloroquine, are critical in treating the autoimmune inflammatory rheumatic disorders. And that includes particularly lupus. Large cohorts have shown that at least 70% of patients are on long-term antimalarials, and quite commonly also patients with rheumatoid arthritis. Now, these medications have multiple beneficial effects in the inflammatory diseases. Again, as you would know, reduced rate of clinical flare, reduced damage accrual, and thrombotic manifestations. And it is thought that this is through a couple of mechanisms, including interference with lysosomal activity and autophagy, and also inhibition of cytokine production through distortion of membrane signaling pathways. Now, these medications have complicated pharmacology, and it is thought that their pharmacokinetics contribute to both the benefits and their long-term toxicity risks. So they have very large volumes of distribution, and they get sequestered in deep tissue, very long half-lives, complicated metabolism, partly through cytochrome P450, and that includes the 2D6 and 3A4 and 3A5 pathways. And even the effects on those enzymes are complex with inhibition and induction. And they also are cleared through a variety of other transport mechanisms. They preferentially accumulate in acidic compartments such as lysosomes and inflamed acidic tissues. And the issue that I'm talking about today is that they inhibit the hydrolases and phospholipases. And this inhibition of the lipases within the acidic compartments, including the lysosomes, is thought to, at least in part, contribute to the eye toxicity, neuromuscular toxicity, skin and kidney toxicity, and particularly the cardiotoxicity, AMIC. And in advanced stages of where patients have accumulation of the drugs within the heart, within the heart cells, the end stage is the development of a hypertrophic restrictive cardiomyopathy. And this is very similar to the genetic disorder Anderson-Fabry disease. And particularly what we see in Anderson-Fabry in middle-aged and older women. Now, AMIC is considered rare or idiosyncratic and has been reported in isolated case series, but there's emerging evidence that it's more common than documented in the literature, and this has definitely been my experience here at University of Toronto. And so I want to actually tell you about the first case that I had of AMIC in my practice here at U of T. This was published as a case report in the Journal of Clinical Rheumatology in 2015. And this was a 74-year-old woman. She had a 40-year history of lupus, diagnosed in 1971. She had a relapsing and remitting course of her lupus with multiple complications as listed here. She was initially treated with prednisone, and then in 2002, she started hydroxychloroquine, 400 milligrams, 6 days a week. She continued on prednisone, 5 milligrams a day, warfarin because she'd had a history of thrombosis, Ramipril and amlodipine because she had a history of hypertension, and some thyroxine replacement. Her lupus was inactive clinically and serologically from 2005. Incidentally, the clinic at University Health Network is sort of a clinical research clinic, and they measure CK once a year, and retroactively we saw that her CPK had been increased to 2 to 3 times the upper limit of normal from 2006, but she had no clinical muscle disease. In 2012, she was referred to me for atypical chest pain. At that time, her lupus was quiescent. Her comorbidities were as listed here. And her cardiovascular evaluation showed a normal ECG, normal troponin. Her stress echocardiogram was negative for ischemia. And really the only findings of significance were that she had mild LVH, and she did have known hypertension prior to meeting me in the clinic in 2012, and some mild mitral valvular disease. She had a cardiac MRI to make sure that there was no inflammatory disease, and this was normal other than the mild LVH that we'd seen on echo. Importantly, there was no LGE, there was no edema. Her symptoms resolved spontaneously. Now, in 2015, 3 years later, she presented with new onset heart failure with reduced ejection fraction with NYH class 4 symptoms. So she had dyspnea, orthopnea, she had edema. And at that time, when I reviewed her, Her ECG now showed new left bundle branch block. Her echo showed new severe concentric LVH plus right ventricular and septal hypertrophy. Her ejection fraction had reduced from completely normal 2.5 to 3 years before down to 35%. She now had diastolic dysfunction, a restrictive filling pattern, and severe biatrial enlargement. Not surprisingly, her BMP was significantly elevated as she now had heart failure, and her troponin, which had been normal a few years ago, was elevated. On her cardiac MRI, it was really notable for very dramatic LVH, and she had LGE, so mild late gadolinium enhancement, in a non-vascular pattern. There was no edema. There was nothing to suggest that this was myocarditis. I had never seen anything quite like this before, and so I referred her to my heart failure specialists for further evaluation because I thought she may need an endomyocardial biopsy. So she was extensively evaluated for potential causes of a hypertrophic restrictive cardiomyopathy, and the workup was negative, including, importantly, for Fabry disease through genetic testing and enzyme testing. She proceeded to have an endomyocardial biopsy, and this was diagnostic for AMIC. There was no amyloid, no inflammation, and I'm going to show you the findings on light microscopy that included endocardial and interstitial fibrosis, hypertrophied myofibrils, and marked vacuolation of the myocytes representing lipid accumulation. Electron microscopy showed lamellar phospholipid membrane stacks and whorls, and importantly, also curvilinear bodies. So this is actually her histopathology. You can see the light microscopy, the arrow shows the important vacuolation, which is the accumulation of the phospholipids in the heart cells. And then you have the electron microscopy findings, which showed these lamellar phospholipids in stacks and whorls, which are also seen in the hypertrophic restrictive cardiomyopathy of Fabry's, but also these curvilinear bodies, which are pathognomonic for AMIC. And so it's important that we see these findings on biopsy, which confirm that this is due to accumulation of the antimalarial within the heart, leading to a lysosomal storage type cardiomyopathy. And these curvilinear bodies are really important. So just to think about the time course of this particular patient, she was diagnosed with lupus in 1971, started the Plaquenil in 2002, then had nothing really to find other than some mild LVH on echo in 2012, known to have hypertension at that time, and then in 2015 had an advanced cardiomyopathy due to AMIC. So for her, we stopped the antimalarial, we treated her heart failure. She had gradual improvement with partial regression of the hypertrophy. Her biomarkers improved, but they did not normalize. The CK, interestingly, that normalized, and she's on guideline-directed medical therapy for heart failure management. I now actually have many more cases since this incident case, and as I'm going to show you, not all have had regression of disease, and many have had progression despite withdrawal of the antimalarial. So this patient was the start of a journey for me and my colleagues with looking at AMIC and doing some clinical research into this area. The first thing we did was a systematic review of the literature, which we published in 2018. We found 48 biopsy-proven cases of AMIC in the literature. Not surprisingly, there was a female predominance, with 43 of the patients found were female. And not surprisingly, also, they were primarily in patients with lupus and rheumatoid arthritis. Mean age of diagnosis was around 56, 57 years, but there was a wide range from 31 out to 81 years. Mean duration of the antimalarial was about 13 years, but there was again a wide range from 2 to 35 years. Those with the very early AMIC were the patients that had very high dosing with their antimalarial before implementation of weight-adjusted dosing. Both chloroquine and hydroxychloroquine were implicated, and 6 of these had reported retinal toxicity. The symptoms that these patients presented with, not surprisingly, a lot with heart failure, nearly 80%, 17% with syncope. 10 patients had biomarkers measured, and 9 of 10 had elevated troponin, and 10 out of 10 elevated BMP. And in 14, 11, where it was measured, 11 had elevated CK. The ECG showed very similar to what I found in my patient, conduction disease with left bundle and right bundle branch block. And a large number of these actually had complete AV block, and 50% had a pacemaker. In fact, a number of these had the pacemakers before they were diagnosed with AMIC. On echo, very similar to what I saw in my patient, LVH, RVH, very common, septal hypertrophy, atrial enlargement, restrictive filling pattern, and a reduction in left ventricular ejection fraction. On MRI, again, hypertrophy, as we saw on the echoes. LGE in a non-vascular pattern, which is what I saw in my patient, was present in 60%. And in this case review, systematic review, 18 of 14 actually died. And of the 22 that survived, 2 had heart transplant. Where there was data, it was shown that there was some recovery in 7 of 11, where there was information provided, regression in 7 of 11, but incomplete, and none of them had resolution of conduction disease. So some recovery in ejection fraction and hypertrophy, but no recovery in conduction disease. So we decided that we needed to look at our own large lupus cohort at UHN in the Toronto Western Clinic. And we did a retrospective review of the lupus cohort. And first off, we looked at our patients that had pacemaker insertion. So out of 1,300 patients, 18 had had a pacemaker. 13 for heart block, 5 for sick sinus syndrome. And we compared them with 34 disease and age-matched controls without pacemaker. In those with the pacemaker, the disease duration was about 22 years, and the mean age was around 60. Those that had pacemakers did have, some of them had risk factors for conduction disease, including coronary disease, hypertension, dyslipidemia, and myocarditis. But 8 out of 18 of our patients had no identifiable risk factors. And most of them, I'd point out, had quiescent lupus. They were very well treated. Pacemaker was associated with duration of antimalarial therapy. And interestingly, most of these patients had retinal toxicity. Unfortunately, most of them hadn't had an MRI before the pacemaker insertion or a biopsy, endomyocardial biopsy. But we do know that they had findings of conduction disease beyond the complete heart block, and they also had septal hypertrophy in 2/3 of these patients. We knew this from the echo. We found that antimalarial treatment duration had a hazard ratio of 1.13 for pacemaker in our patients. And when we looked closely at the possible causes, we found that in total, 8 of these patients were likely to have had the pacemaker actually due to antimalarial-related toxicity. So the next thing that we did was we looked at whether or not doing cardiac biomarkers, so troponin and BMP, may predict risk of toxicity in our patient cohort at the Toronto Western. And so what we did was we took 151 consecutive patients attending the lupus clinic, and they were consecutive patients, but patients with no known history of heart disease or pulmonary hypertension and no ECG abnormalities to suggest coronary disease. So this was just a random selection, consecutive 151 patients. We found in these patients 16 had abnormal biomarkers. That's 11%. Abnormal biomarkers was associated with older age, longer disease duration, and antimalarial therapy. And when we did multivariable logistic regression analysis, we showed that prolonged antimalarials beyond 5.6 years, and also, interestingly, a persistent increase in CPK were predictors of elevated biomarkers. So we went on and we actually worked up these 16 patients, and we found 6 had definite based on biopsy or probable based on MRI, AMIC. And the remainder we had found they either had no cause identified or something like renal disease. But that was pretty shocking to find 6 of these patients out of 151 consecutively attending the clinic having AMIC. So the next thing we thought about was how can we improve early detection beyond biomarkers in our patients? Because AMIC has a high morbidity and high mortality. Heart biopsy is the gold standard, but it's obviously invasive, there's risks and problems with accessibility. So we wondered whether or not cardiac MRI might provide a reliable diagnosis instead of having to go to biopsy. So we retrospectively reviewed all the patients with lupus who'd had a cardiac MRI over a 10-year period from 2008 to 2018. And we excluded the patients that had a diagnosis of myocarditis. We had 11 patients that had AMIC based on biopsy and or expert consensus, and we compared them with 29 patients with no AMIC. And when we compared the two, we found that LVH was highly prevalent in the patients with AMIC, up to 91%. LGE in a non-ischemic pattern, basal, infralateral, and mid-wall was present in 100% of our patients. So LGE was very prevalent in the AMIC, but only seen in 21% of the patients that had no known AMIC. So LVH and LGE were very important. And we looked at the area under the curve to discriminate AMIC from non-AMIC, and we found that the combination of LVH and basal infralateral LGE plus treatment duration with an antimalarial more than 10 years had a sensitivity of 90% and a specificity of 100%. When we looked at just the basal infralateral LGE alone on the MRI, that had a sensitivity of 90% and a specificity of 97%. So these findings are really important. So the next thing we did was to look at whether or not doing some advanced T1 and T2 mapping in these patients may also help us diagnose AMIC perhaps earlier in the course of the disease and the toxicity. So we evaluated the cardiac MRI parametric mapping findings in patients with lupus with AMIC, and we investigated the relationship between T1 and T2 mapping to antimalarial treatment duration. And so we looked at all the patients with lupus who'd undergone MRI with T1 and T2 mapping to evaluate for suspected cardiac disease between 2018 and 2021. And we compared these patients with MRIs in patients with known myocarditis and in healthy controls. Now, I'm not a radiologist, but T1 generally reflects fat accumulation, fibrosis, iron accumulation, and edema. And T2 tends to reflect water accumulation and edema. So, and we know that T1 and T2 mapping is very important in Fabry's disease, where they present with a very similar lysosomal storage cardiomyopathy. So we had 45 patients with lupus, 8 with AMIC, 7 with known myocarditis, and 30 with neither AMIC or myocarditis, and we called them lupus other. And we had 30 healthy controls as well, where we had MRI data. Now, what we found was that in patients with established AMIC, they had higher T1 anti-T2 mapping versus controls and versus patients with lupus other, so patients without AMIC and without myocarditis. The patients with AMIC did have lower values of T1 and T2 compared to patients with myocarditis, which is not surprising. Now, what we have on the left here is the graph that shows native T1 mapping on the y-axis and antimalarial treatment duration on the x-axis. And we have the patients with myocarditis are in the sort of orange color. The SLE other, so patients without established AMIC are in blue. And the patients with AMIC are in this sort of red color or maroon. And what you can see is that the T1 negatively correlated with antimalarial duration in the patients without AMIC. But there was an inflection point and there was a positive correlation of increasing T2 in patients with established AMIC. And this is really important because this is similar to what is found in patients with Fabry's. So we're seeing this native T1 decrease with longer duration of antimalarial therapy in our patients who have not yet developed AMIC. And it is thought that this is due to accumulation of lipid in the earlier stages of the development of toxicity. And then when we see the T1 increase in patients with established AMIC, this is where the development of fibrosis sort of overpowers the accumulation of the lipid, and we're seeing this increase in T1. And so this inflection point may actually reflect an important stage for these patients where they go from lipid accumulation to starting to get the severe and irreversible fibrosis, and then where we would also see LGE on MRI. So another thing that we looked at was whether or not there was progression of MRI abnormalities in our patients after they stopped the antimalarial therapy. Anecdotally, I'd seen patients progress, but we wanted to see what we saw on imaging. And so we did a case series. This was published in 2023. We did a case series of 9 patients with lupus and AMIC. And we looked at their MRIs that were done at baseline when they stopped the antimalarial because of the diagnosis of AMIC. And they had a follow-up MRI, a median of 1.5 years later. And you can see these 3 graphs. We have LGE, ejection fraction, and left ventricular mass. And we have baseline and follow-up for each of these abnormalities. And you can see there was an interval increase in LGE in 89% of the patients, almost all of them. There was an interval decrease in ejection fraction in all of the patients. And there was no change, so no regression in the left ventricular hypertrophy in any of these patients. So what we're tending to see here is progression of the disease on the MRI. The high sensitivity troponin remained elevated in all of these patients. There was 1 death and 2 of these patients required a pacemaker. And those that actually had the worst outcomes had the highest LGE. And this is just giving you an example of a 50-year-old woman who has AMIC, and she had a baseline MRI that showed the basal infralateral LGE. And then when she had the follow-up MRI, this was actually 4 years later, she had this progression in the LGE so that it actually involved much more extensively the left ventricular wall. And again, this patient stopped the antimalarial at the baseline MRI. So I just put together this diagram or algorithm to describe what we're seeing in the pathophysiology of AMIC. So when you have prolonged antimalarial exposure, This leads to decreased lysosomal phospholipase and hydrolase activity and accumulation of phospholipids in the heart, within the heart cells, the cardiomyocytes. We see vacuolated cytoplasm, hypertrophy of the cells, fibrosis and apoptosis, and eventually we get a clinical lysosomal storage disease phenotype with myocardial necrosis, pressure and volume overload, conduction disease, and the morphological changes of hypertrophy. So a number of us in my cardio-rheumatology world are getting quite concerned about this, and we don't at the moment have evidence-based guidelines as to how we should be screening for for this toxicity in the way that there are for eye toxicity. And so with some colleagues of mine from Harvard and New York University, this was both cardiologists and rheumatologists, we developed preliminary screening recommendations so that there's some guidance for rheumatologists and cardiologists with respect to working up your patients for the development of antimalarial cardiotoxicity. And this was actually published by the American College of Cardiology in February of 2025. Now, we have in this document, we've provided information, for example, on this slide here, clinical manifestations of plaque toxicity. So what I've been talking about, presenting symptoms can be asymptomatic, but they may have cardiac biomarker elevation, troponin and BMP. They may have some conduction disease seen on ECG, but it can be asymptomatic, but it can progress to being palpitations, syncope, and even sudden death. And then a variety of different structural and functional abnormalities that we can see on echo and MRI. So the characteristics that you find on diagnostic evaluation, again, are very similar to what I have discussed in my first index patient and in the systematic review. Persistent elevation in biomarkers. Conduction disease can be anything, ranging from early in the disease prolongation of the PR interval, so it may just be first degree AV block that you see develop, or it can be as advanced as third degree. It can be any type of bundle branch block or QRS widening, ventricular arrhythmias, atrial arrhythmias, and QTC prolongation that we know occurs in patients even within 2 days of starting antimalarial therapy. The structural disease that I've talked about can be hypertrophy of left and right ventricles and the septum. Atrial enlargement, it can be one atrium or both biatrial. It can be new valvular disease. This is something we see, but it's less common. And of course, the LGE in the non-ischemic pattern. Diastolic dysfunction that you see on echo is important, and then systolic dysfunction with reduced both left ventricular and right ventricular ejection fraction may be seen. The earliest way of detecting abnormal contraction of the ventricle is actually with strain, and this is something we're looking at right now to see if this can also help us when we're trying to screen our patients. Now, this is a risk-based approach to monitoring and evaluation. So what do we know about risk factors for antimalarial cardiotoxicity? As I've shown you today, the duration of therapy is important, and after 5 years, in some patients, we're starting to see toxicity. Daily dose and cumulative dose are important, so more than 5 milligrams per kilograms per day, or cumulative dose more than 500,000 milligrams. Patients with renal insufficiency and chronic kidney disease seem to be at increased risk. This may be reduced clearance, or it may be they're even developing some background kidney disease, we're not sure, related to the antimalarials. Patients using NSAIDs also seem to be at increased risk, as do those with pre-existing heart disease of any type. And then the presence of other forms of antimalarial toxicity, particularly retinal toxicity, that's very important and puts these patients at high risk. So this is the algorithm that we developed. It looks a little bit complicated, but hopefully people can follow this when if they do look at the paper. So this is monitoring for asymptomatic patients. So if your patient is very low risk, so you have no risk factors, and we are recommending at commencement of therapy that you obtain an ECG, and that if the patient does have long-standing hypertension or established cardiovascular disease, you do an echo at baseline as well, because this will guide you over the coming years as to whether or not there's anything new that develops. My first index patient, you remember, had a little bit of LVH, but I thought that was due to her background hypertension. And I do have a hypertension clinic. Now, if they are lower risk, so they have between 1 and 3 risk factors, do an annual ECG to look for any subtle changes in cardiac conduction. If they're higher risk, so they have 4 or more risk factors, or they've been on therapy for 5 or more years, we're recommending annual ECG and echo. Now, if they have abnormal findings, we move on to the next algorithm. Again, it looks a little complicated, but work with me here. If the patient is developing symptoms or has new findings on ECG or echo, this is what you'd follow. So if they're low risk and the ECG is actually not changed, nor is the echo, but they've got symptoms, you really do need to rule out any other cause of their symptoms. And, I showed that slide that showed the myriad of potential cardiac complications you may see in your patients. If they are moderate risk or they're higher risk and they have abnormal ECG, so new conduction abnormalities or arrhythmias, and or new findings on echo that I've talked about, particularly hypertrophy, systolic, diastolic dysfunction, restrictive filling pattern, then you need to proceed to an MRI. And that's looking for the LGE, the hypertrophy that I've talked about, systolic dysfunction. And if they have conduction disease of any sort, do 14-day Holter monitoring, because they are really at risk of significant arrhythmias and conduction abnormalities that can cause significant morbidity. So new abnormal findings, cardiac MRI, Holter monitor. If on the MRI it looks like AMIC, then we would strongly recommend you consider stopping the medication. And we always collaborate between cardiology and rheumatology, and I hope that that can be the case in other centres. I would point out many cardiologists still are not familiar with this disorder and may need a bit of education. If there's still uncertainty, then it may be necessary to do a biopsy in your patients. We had a patient just recently where we'd stopped the antimalarial in 2017, and she developed severe heart failure and conduction disease. We thought it had to be something else, but we proceeded to biopsy, and it was AMIC. So I'm going to give almost the last slide to the rheumatologists and draw your attention to the white paper that was published back in 2021 in the pandemic, when people were talking a lot about hydroxychloroquine. And this looked at antimalarial cardiotoxicity. In this paper, they talked again about how invaluable these medications are in the rheumatic diseases, but that long-term use of the antimalarials can lead to this cardiomyopathy that I've been talking about today with arrhythmias and heart failure. They say that you've got to really pay attention to this, because it certainly can cause significant morbidity and mortality. And that if we're all aware of this, in rheumatology and cardiology and primary care as well, it can increase the safe use of these medications. So if you think about it with these patients, they start off at time 0, asymptomatic. They have a lot of benefits for the autoimmune and inflammatory rheumatic disorders and for cardiovascular health when treated with these medications. But with time, you start to get to this inflection point where you're having the accumulation within the heart that starts to develop into the findings of hypertrophic restrictive cardiomyopathy with the timing and the risk related to the risk factors, particularly duration of therapy, leading to this hypertrophic restrictive cardiomyopathy. So in conclusion, is AMIC rare or under-recognized? I would say that it's under-recognized. That's certainly been our experience here at University of Toronto, and we're doing a lot of screening now of our patients, and we're picking up a lot of patients. And you really need to think, if somebody in your, particularly your lupus or your RA cohort that are on antimalarials develop unexplained heart failure, conduction disease or hypertrophy, to think about, is this related to their antimalarial? It has been and will continue to be mistaken for other pathologies. And just like the patients we had in our cohort that had pacemakers where they hadn't been diagnosed with AMIC. And we also need to be aware that patients can have AMIC and other pathologies. We mustn't forget that. We have to be thinking outside the box. And the outcomes are not predictable. In some patients, there is regression. Some show progression. And in some, I'm seeing some that are sort of stationary and unchanged. There is this high morbidity and mortality rate if late diagnosis. What about the future directions? Well, we really need to be collecting prospective data for the development of evidence-based screening recommendations so that we can detect this early before the development of the irreversible and progressive disease. We need to also have enough evidence to know when we should be timing the withdrawal of the antimalarial. We wonder whether T1 mapping, for example, where you have that inflection point with the reduction in T1 over time with accumulation of antimalarial before you start getting fibrosis, maybe that will help us with the timing, but we need more data. We also need to have some further research addressing the variability in time to onset of toxicity. And why do some patients develop earlier? It's more severe, why they progress while others may reverse. Is this genetic, related to the way, for example, the genetic metabolism? We know 2D6 in particular has genetic phenotypes. Is it related to disease factors or other factors that we don't know about? And we really need to focus also on knowledge translation, particularly in rheumatology and cardiology. And I'm very appreciative of being able to be here today to talk about this actual disorder. And I'm going to finish off with what I call the U of T AMIC team. This is a team, and it involves cardiologists, not just myself, but Dr. Aktari and Dr. Ocean Token, who work with me here in Cardio-Rheumatology at Women's College Hospital. My colleagues in rheumatology at Toronto Western Hospital, Costas Zelius, who you may know, he was a fellow at the time when we did a lot of this work. He's now on faculty at McMaster. Murray Urovitz and Daphne Gladman, and also Zahi Tuma, who I continue to work with in this field. My colleagues in radiology, Dr. Hanneman has done amazing work with the MRI imaging, Dr. Mack in advanced heart failure, who did the biopsies, and also Dr. Butani who did the pathology for us. And with that, I'm open to questions, and I do apologise for all these technical problems.
Thank you so much for that wonderful talk through the pathophysiology, clinical research, and screening and treatment recommendations for AMIC and your important work in the area. We have about 5 or so minutes for questions in the room. Dr. Yansuni, if you'd want to.
Thanks. Hello, it's Cedric Yansuni. I work in tropical and infectious diseases here. Thank you for educating me. I had no idea that this entity existed, so I walk out of here smarter than before. I have a question and a request for your consideration. In infectious diseases, perhaps contrary to your talk's title, the only entities where we actually treat long-term with hydroxychloroquine at comparable doses is things like Q fever or Whipple's disease. And even then, it's sort of limited to a year. So my question for you is, in your data, is there an evidence-based concern for treatment of what we think is long-term, so for a year, in patients who may already have some cardiac morbidity?
Thanks for the question. I would say no for the antimalarial cardiotoxicity. You obviously would be aware about QTc prolongation, but as you saw when we did the systematic review, the shortest period of time was 2 years that was seen. Now, that was in patients with non-weight-based dosing, but I would say that they presented with advanced disease, but we're not seeing it in our patients within the first few years, but we are certainly seeing it after 5 or 6 years. So I think even if your patient has established cardiovascular disease, you're probably not going to see any sort of toxicity in your patients with just 1 year of treatment.
Sure, thank you. And then if I may, just with a quick request. So, when I realize you didn't invent the term antimalarial cardiotoxicity, but I would propose that it's a little bit misleading because it's not a class effect. It's a very specific drug that is almost never used anymore in malaria. And even when it is, it's used at 1/14 the dose that other people use it. And in my clinic, we do have a problem with patient skepticism about malaria prophylaxis, but in 99% of cases, it's with other drugs that have nothing to do with this. So your work may make my life more difficult. So if you could spread the word and maybe consider changing the name to hydroxychloroquine associated cardiotoxicity. There, I've said it. Thank you very much.
Unfortunately, it was shown with chloroquine as well, but we don't use as much, or the rheumatologists don't.
Same issue, right? So when you give it for prophylaxis, you give it at 400 Q week. And you give it for treatment, you're giving 2 grams over 3 days, and then that's it. So different, very different. Anyway, thank you.
Thanks. Point definitely taken. I understand.
Maybe I'd invite Dr. Mandel to unmute and ask her question.
Hello, can you hear me?
Yes, I can.
Okay, so I'll just read out. I didn't know how easy it would be to talk out loud, so that's why I typed it all out. But so there's 2 questions. I guess maybe I'll start with the second question, which is obviously you haven't done a population-based study, but it would be really nice if we could have the ability to quote an absolute risk over a period of time. When we're initiating patients on antimalarials, we always talk about retinal toxicity and the need to start annual screening after 5 years. And I usually quote a 1% risk of maculopathy after 10 years of continuous use. And that tends to kind of put things in perspective for patients because they're not even like, they're realizing that it's a pretty low risk, even if they continue it for 10 years overall. Of course, that changes if they have other risk factors like chronic kidney disease and things like that. But, so I think it would be nice if we all started talking to our patients about the risks to the heart and potentially muscles when we start. But at the same time, we don't want to make our patients too afraid because this is the safest drug we have in lupus. And it's really, there's so many benefits for lupus. So it'd be nice if somebody was working on the ability to tell people, for us to be able to say, what is your absolute risk? Because I suspect the majority of people won't run into having this problem. So that was sorry, you can answer that question.
I totally agree with you that we need more data. We're way behind eye toxicity. I'm seing a lot of it in our lupus cohort. So as is Dr. Toomer that I'm working with, but we are interested in working together across the country. Sasha and Zahi and myself, and maybe working with our colleagues in the US to see if we can actually develop a research collaboration so we can collect the prospective data. In fact, I had Dr. Jurovitz and I had funding for a prospective study, and then COVID hit. And it sort of fell in a hole, which is really unfortunate because Dr. Jurovitz, I'm sure everybody knows Murray Jurovitz, he retired, and we were going to then do the study with Dr. Gladman, but she's sort of partially retired now too. So it's really important work, and I'm hoping that we can collaborate across Canada and with our colleagues potentially to the south of the border so that we can get the data, because we just don't know at this stage. So this is the sort of thing that we need to get the evidence on so we can be advising our patients and providing better evidence-based guidelines, and maybe some of the genetic testing, looking at why do some patients do develop this more quickly than others. It's more than just dose. It's more than just those risk factors. There's something else that's contributing, and so there's a lot of work that needs to be done. So they're great points.
Maybe just a very quick second part of that question, Ariel, and response. We're at 1 o'clock.
Yeah, so I mean, this is not even a discussion only for you, but for other folks here. I mean, if we were going to operationalize annual screening for people with lupus on antimalarials, or we'll call them hydroxychloroquine or chloroquine, it would be very difficult. Currently, if I order an echo for symptoms, it will take at least a year sometimes. And they've actually started implementing a process to triage echo requests based on BNP, with the idea being that if you have a normal BNP, maybe you don't need an echo, or it's very unlikely that you're going to have an abnormal echo. So I'm wondering if this was considered when you were making the guidelines, and if you've ever seen somebody who had an abnormal echo and was later found to have AMIC who had a normal BNP.
Yeah, that's a great question. Not every patient has an elevated BNP, so it depends on what they are developing first with respect to the changes that we see. Some of them just develop the conduction disease before they develop morphological disease, or they may develop the LVH but not the reduction in ejection fraction and heart failure. So the BNP is a good marker when it's elevated, but there are a lot of patients that don't have BNP. We see more elevated troponin actually than BNP, but I know troponins are tricky as well. In fact, when we did the recommendations, we didn't include BNP and troponin, and I got some feedback from Dr. Jurovitz that was a mistake because he felt we should be including it. But that was because even at Harvard, they can't get ambulatory troponins and BNPs for their patients without a lot of expense or a lot of difficulty. So we do understand different regions have different problems, and so your problems with echoes are obviously really concerning. And we are privileged at U of T where we can get our echoes more quickly. So we're trying to think how people can do this. The ECG can be helpful. A troponin can be helpful if you can get one. Recognizing not everybody can even get a BNP. But there are patients who have abnormalities on ECG and or echo with a normal BNP. So, this is also where it gets tricky, where we're trying to get more evidence about what we really need to be focusing on as we're doing the screening. We sort of settled on ECG because it's cheap and people can do that once a year. Echo, there's obviously access issues, but most people can get it, certainly in Ontario, but clearly this is not the case everywhere. And so more data, more evidence.
Great.
So that can help. Yeah.
Again, thank you so much for an excellent presentation and discussion, and wish everybody a great afternoon.
Thanks very much.
Thank you.